Okay, welcome to Pain Forum. Um, for those of you who are new to Pain Forum, it's a quarterly free lecture series organised by the Bath Centre for Pain Services. The Bath Centre for Pain Services is a national specialist rehab centre for people of all ages with chronic pain. My name's Jen, and I'm a consultant physio and I'm the therapy lead here in Bath. And I have the absolute pleasure of introducing our speaker today, and I'll also be coordinating the questions. This event will be recorded, and you'll all receive a link via email in a few days' time if you want to watch back or if you miss anything. For questions today, we're going to use the chat function. So please, can you put all your questions on there, and I'll try to keep track of them and pose them to our speaker at the end. So I'm really excited to introduce today's speaker. I think we've been waiting a while for this presentation, but we've got Dr. Lauren Harrison, who's a clinical assistant professor from Stanford University. She's an NIH-funded investigator and clinical psychologist whose research focuses on pediatric chronic pain with a particular emphasis on biopsychosocial mechanisms, health equity, and scalable digital interventions. Her work, which I'm sure many of you know, has contributed to emerging evidence on disparities in pain-related functioning among sexual and gender minority youth. And this has really advanced best practice recommendations for inclusive assessment of sexual orientation and gender identity, both in pain research and in clinical settings. And as well as all of that, Dr. Harrison is also an attending pain psychologist at the Lucille Packard Children's Hospital. So thank you so much for joining us, Lauren, and I'm going to hand over to you.
Yes, thank you so much for having me. Just want to make sure you can hear me okay. Jen, okay, perfect. So yeah, thank you for being here today. I'm really excited. Had the pleasure of connecting with Jen at a pediatric pain meeting last summer, and I'm very happy to be here now. Jen, is it best if I just say like next slide or? Okay, so go ahead and that would be great. Just briefly, I'm sure we're all familiar, but pediatric pain is it's a big health burden affecting approximately 1 in 4 children, and leading to significant healthcare related costs globally, with some specific data presented from the US. And we know that youth with chronic pain are at increased risk for anxiety, depression, and sleep disturbance, all of which exacerbate pain and significantly impact multiple domains of functioning. And when we think about chronic pain, we typically think about it developing from a complex interplay of biological, psychological, and social factors. Next slide. With stress emerging as sort of a critical factor influencing pain, sensitivity, and related impairment. And specifically, this is sort of this compounding effect of interpersonal and social stressors in conjunction with individual factors. And to date, the research that's been done on sort of stress in the context of pediatric chronic pain has focused mostly on early life adversity, such as adverse childhood experiences or ACEs or other acute stressors, with limited attention given to pain-related disparities in vulnerable populations that are known to be at risk of experiencing increased system-level stressors. Next slide. And when we think about those vulnerable populations, sexual and gender minority youth are one of them. So these are youth who identify as lesbian, gay, bisexual, transgender, queer, intersex, or other diverse identities. And it's estimated that just under 10% of youth ages 13 to 17 in the US identify as a sexual and gender minority youth. Let me just progress this slide. You can just hit it twice, Jen, that'd be great. Oh, sorry. Would you go back? Perfect. And we know a significant portion of these youth report significant marginalization and discrimination based on their identities, and that this persistent discrimination and marginalization is associated with a higher risk of physical and mental health conditions compared to youth who are cisgender and or heterosexual. Next slide, yeah. And the minority stress theory is the framework that really helps us understand how different distal and proximal stressors contribute to poorer mental health outcomes and physical health outcomes in youth. And there's, Jen, if you could just click the slide, there's a couple of pop-ups. Yeah, and so underlying the concept of minority stress are assumptions that certain social stressors are unique, meaning that they're not things that are experienced by people who are in non-stigmatized populations. These stressors are chronic and they're additive. So the general stress, there's this compounding effect of experiencing these stressors over time. And if you'll just click the slide, I think one or two more times. Yeah, one more time. Thank you. And I think recently to this model, and importantly, was added this protective factors layer, where we're really starting to consider, in the face of all of these stressors, what are some protective factors at play that can enhance or mitigate the negative effects of some of these minority stresses. Next slide. And we know that chronic exposure to minority stress can disrupt the HPA axis, leading to elevated cortisol production. Jen, if you'll just click the slide twice. We also know that this leads to increased blood pressure, heart rate, elevated inflammatory markers. And all of this has been demonstrated in the research that's been done in sexual and gender minority youth outside of sort of the context of chronic pain. And together, all of these biological concept or constructs make up the concept of allostatic load. Next slide. And allostatic load is a multifactorial construct that represents physiological wear and tear on the body's nervous system due to significant and prolonged stress. And we know that this leads to pretty significant health issues over time. Next slide. And there's growing evidence linking allostatic load to the development and the progression of chronic pain. So these are a few recent studies done by Sarah Nelson, who is a pain psychologist at Boston Children's on the East Coast here in the States. And one of her recent studies examined biomarkers of allostatic load in youth with chronic pain and found that over half of the sample classified as high risk for allostatic load, meaning that they had two or more of those risk factors. So elevated cortisol, DHEA, C-reactive protein, high BMI, and that signals sort of a higher risk for this chronic sort of state of being an allostatic load. And Sarah also found that high risk for allostatic load was significantly associated with greater depression, pain catastrophizing, functional impairment, and worse sleep in youth compared to those youth with chronic pain who did not have high allostatic load or high risk for allostatic load. Next slide. And results from these studies lay the foundation for us to begin to understand the manifestation of allostatic load in pediatric pain. But there's limited research specifically examining the role of allostatic load in chronic pain among sexual and gender minority youth, despite these youth demonstrating increased allostatic load compared to cisgender or heterosexual counterparts. And this really represents a critical gap in understanding the intersection of minority stress and our biological stress pathways and then associated pain disparities. Next slide. And so a few years ago, together with some colleagues, we put forth this model that was actually a model that was adapted from sort of understanding the impacts of cumulative stress and chronic pain in Black men. And we modified this to start to theoretically try to map out and understand what might be at play for LGBTQIA plus youth. And so within this model, you have biopsychosocial and ecological factors at the individual, the relational, and the societal level. And these all are interacting with each other and interact with factors like marginalization and discrimination and poor social support, increasing the risk for developing chronic pain. And these factors influence psychological functioning and psychosocial responses to pain, which together with this impact of cumulative stress over time increase the risk for pain and negative pain-related outcomes. And I think what's important and it was really the thing that kind of got me into doing this work is despite sort of this increased risk and certainly anecdotally working clinically, seeing a high number of patients coming into our chronic pain clinic who are having these identities, there's really nothing that sort of exists in the literature to speak to the prevalence of chronic pain in these youth. Next slide. And Jen, this one has like a couple of animations. I'm sorry, you're welcome to just click through. But of the scant literature that does exist, we see signals for high rates of chronic pain and pain-related disparities. So these are data specifically speaking to sexual orientation and pain in youth using a large national sample. And we see higher rates of like higher severity ratings for pain and also frequency of pain in youth who are identifying as bisexual or lesbian/gay compared to heterosexual. But those were the only two ways in which sexual orientation were assessed. The option was like heterosexual, bisexual, or lesbian and gay. So not super robust. And gender identity wasn't assessed at all in this sample. If you'll progress the slide again. Yeah. Sorry. Perfect. And a lot of the research that's been done on gender identity, and we're separating that from sex assigned at birth, has been limited to case reports or case studies, but still signaling greater depression, functional disability, and fear of pain compared to matched samples of cisgender youth. But I think one of the things that has stood out to me in the literature is there has been this sort of historical conflation of sex and gender and really trying to tease out the biological aspects of sex with someone's gender identity and how they present socially and the impact that that can have on their everyday experiences. Next slide, please. And so the Trevor Project is a nonprofit organization here in the States that is really focused on sort of the mental health of LGBTQIA plus youth. And they, I believe starting in 2019, started to, through a series of surveys with these queer youth, really expand the way we're assessing these identities. Next slide. And I was just these next few slides, I'm gonna walk through sort of the process of how they develop these items because I think it's interesting and it sort of speaks to the importance of bringing in lived experience into the work that we do. But so the initial survey in 2019 assessed sexual orientation using these items. And 78% of youth selected like gay or lesbian, bisexual, and 21 selected something else. And so an examination of those write-in responses realized that 92% of youth's identities would have been captured if they would have included pansexual and queer as choice options. Next slide. And so these were added into the 2020 and 2021 surveys. And these data indicated that the majority of youth who declined to select a category described themselves as asexual. And so they added that in, and these were the items that were selected as sort of the best practice recommendations for assessing sexual orientation. Next slide. And when we think about the assessment of gender identity, this has also fallen short. Jen, if you'll just advance the slide, there's some things that will pop up. Perfect. So the 2019 survey assessed gender identity using this two-step question. So first, what sex were you assigned at birth, male or female? And then what is your gender identity? And data from this survey indicated that the majority of youth who selected a different identity wrote in non-binary and gender fluid. Next slide. And so those were added in, and then the additional feedback received from youth through this iterative process resulted in trans man and trans female being removed because the youth were reporting that having man and woman as an option and then trans man and trans woman negates the fact that a transgender individual is the identity that they are identifying with. And so this is where from an understanding of identity, but if we're thinking about integrating these items into research, this two-step question is really important because from here, we can sort of look at sex assigned at birth with gender identity and have a very clear understanding of who is a transgender individual and who is it, but without having to be dismissive or minimize the gender identity that they hold. Next slide. And there was some similar items developed in the adult research space. And we took the Trevor Project items and those items that have been developed in adults and put forth this call to action to integrate these items into our pain research and our clinical care. Next slide. And so I just present them here. So this is sort of what is put forth in our paper for best practices. So you can see we start with an open-ended response, which I think is really important when we think about how much language is evolving and identities are evolving. And I think this is the best way for people want to communicate their identity, and then below have them pick a forced choice option. But it also gives us ongoing insight into what are some other identities that might be emerging as language evolves and our understanding of these things evolve. And then the next slide shows the best practices for assessing gender identity. So again, starting with an open-ended question and then having those two forced choice options. And we have ours situated where they identify their gender identity first and then they select sex assigned at birth. And just as an example for how frequently things I think are iterating, this paper came out at the beginning of 2025 and we've already updated the sex assigned at birth to include an intersex option, which wasn't included in the items in the paper that we just recently put out. Next slide. Perfect. And so as we were sort of preparing this paper, it felt really important for me to get these items at least into our pain clinic and start to understand what are the rates of these identities that we're seeing in our clinic. So this was in our outpatient pain clinic, which sees roughly 350 new patients a year. All patients complete what's called PEDS Choir, which is a self-report battery of promise measures, sort of giving us a sense of their pain and related functioning. And so we integrated these items at the end of 2022. And the data that I'm going to present now goes through August or maybe December of 2024. And this paper, Jen, if you want to go to the next slide, was just accepted in pain at the end of December. Next slide. And if you'll just kind of pergor, there's like 3 little boxes that'll pop up. Perfect. That's actually perfect. And so what we were really aiming to do here is building off of the theoretical model, that we had put forth several years prior, but assess sort of baseline rates of these identities, but then also examine pain-related psychological and physical functioning in these youth. And then examine whether psychological distress, so anxiety and depression, mediate the relationship between pain and related impairment in cisgender youth and sexual and gender minority youth. Next slide. And so what we did here is just create two groups. So if an individual was cisgender and heterosexual, they were in one group, and any youth who was not those things was in our sexual gender minority youth group. So we had we had 382 youth in total between the ages of 13 and 19. And you can see sort of average age and standard deviation for each of those groups here, pretty similar. You can also see rates of the various pain diagnoses between these groups. And the proportions, when looking at the percents, are fairly similar. But what was striking is that close to a quarter, so it's, I just believe, just under 26% of youth in our clinic were identifying as a sexual and or gender minority. And again, the base rate of those identities in the general population in the States is 9.5, so significantly higher. And if you go to the next slide, I just have sort of a frequency count of each of these identities for the youth. So there's some overlap within these numbers, because you could have someone who identified as non-binary and also queer or pansexual. So those numbers don't total 380, but just to give you a sense of what is the distribution of gender identity and what is the distribution of sexual orientation. And here we present sort of the calculations that we did looking at concordance and discordance and sex assigned at birth and gender identity to be able to just illustrate how many individuals were identifying as transgender specifically. And next slide. And if you click it twice, there's two little boxes. Perfect. So what was, I think, interesting here is that we don't see any significant differences when we compare those two groups to each other for pain intensity, pain duration, or pain-specific variables like pain catastrophizing, pain-related fear, and pain avoidance. Next slide. But what we do see are significant differences. So higher impairment to mobility, higher impairment to pain interference, fatigue, anxiety, depression, and sleep impairment for the LGBTQ plus youth compared to their cisgender heterosexual peers. And what stands out to me here, just in case people aren't familiar with the PROMIS measures, is that pain interference is the only one of these measures that's specific to pain. Mobility and fatigue are assessing those areas just broadly, so not related to pain. And similarly for anxiety, depression, and sleep. Next slide. And I included these violin plots just to sort of show that when we look at the distribution of these scores within these two groups, for the cisgender heterosexual youth, we see most of the responses clustering around like sort of the normal range. So PROMIS measures are scored on a T-score. So anything 60 and above is sort of considered elevated, with anything 40 to 60 within normal limits. And so we just see like wider distributions in the sexual and gender minority youth up in those clinical ranges than whereas for the cisgender heterosexual youth, they're clustering more sort of within or closer to normal limits. And so this is showing mobility, pain interference. The next slide, we have fatigue and sleep impairment, and then anxiety and depression. And so next slide, We then just ran some sort of analyses of indirect effects, and just to sort of explore what are sort of the combined effects of psychological distress on each of these dependent variables that are looking at sort of pain and physical functioning broadly. And then next slide. So this is our first model, looking at sort of the impact of these on pain interference. And when we had anxiety and depression included, they both sort of fully, I don't want to say the word mediate, these are cross-sectional data, but accounted for the relationship between sexual and gender identity and pain interference. And depression demonstrated a slightly stronger effect than anxiety, but they were both sort of fully accounting for the differences that we were seeing in pain interference. Next slide. And this was not the case when we looked at mobility, fatigue, and sleep impairment. Again, so these are those broad measures of functioning that are not pain specific. So we saw here depression and anxiety, sort of this concept of psychological distress, partially accounting for the relationships between sexual and gender identity and these outcomes, but not fully. And what that was really signaling to us is that there are additional factors besides anxiety and depression that contribute to the relationship between sexual orientation and gender identity and these broader sort of measures of function within this population. Next slide. So just some sort of key summary findings here. Perfect. I think striking and was corroborating what we were at least seeing anecdotally in our clinic is that a quarter of youth in our sample identified as sexual and gender minority. And when we looked at sexual and gender minority youth compared to cisgender heterosexual youth, we didn't see significant differences in average pain duration, and pain-specific variables. But these youth reported significantly greater pain-related interference and mobility impairments. And this really suggests that the experience of pain and pain-related psychosocial responses is similar in cisgender heterosexual youth and sexual and gender minority youth, but that the impact of pain on their daily functioning is potentially more severe. And it suggests that we need to be sort of looking at what else might be driving this, and really starting to think about, are these youth experiencing more daily impairment due to cumulative burden of psychosocial stressors? Next slide. The youth who identified as LGBTQIA also reported greater depression and anxiety. And these variables were really accounting for a lot of the differences in pain interference, but only partial differences for the other broad measures of functioning. And again, this suggests that anxiety and depression play a key role in functioning, but there are likely other factors that are leading to impairment broadly across mobility, fatigue, and sleep impairment. Next slide. Yeah, you can click through it. There's like 5 bullets, I think, Jen, if you wanna. I'll just sort of run through them once they're up. Yep. So these are preliminary data, I think, is how we should conceptualize them, but I think they're significant and they're important, but it's also important to name the limitations. So these were cross-sectional data, which obviously precludes our conclusions about causality. So while we ran analyses of direct effects and they provide support for the role of psychological distress and pain-related impairment, we're limited in our interpretations of that. And I think having future longitudinal research that clarifies the temporal order of the relationship between these hypothesized mediators and the dependent variable is really important. I think there's a lot of limits to generalizability here. So thinking just in the context of the United States, these data were collected at a single tertiary care clinic on the West Coast. Demographically, sociopolitically, we are different than a lot of the rest of the country, particularly now. So I think replicating this study across other geographical areas, and having also a specific focus on the intersections of other aspects of identity, so race, socioeconomic status, is also imperative to help give us a better understanding of what other cumulative and social stress factors might be at play here. And I also think, these youth in general face a lot of access to care barriers when it comes to getting into healthcare systems. And I'm referring to youth with chronic pain and sexual and gender minority youth. So I think it's important to understand that the youth that were making their way into our clinic are likely not fully representative of the experiences of youth with chronic pain and sexual and gender minority youth broadly. And this is really where it's important that we take our research outside of our clinics and outside of our hospital systems and into the community. We also examined all sexual and gender minority youth as a single group, which presents sort of analyses of differences within this sample. And I think this is something that's really important as we move forward in this work, is to be able to have sample sizes that are large enough that allow us to understand sort of the differences that exist even within this group. Because I do think we will see subgroup differences between youth who identify, for example, as transgender versus a youth who is like cisgender and identifies with a queer sexual orientation. And I think understanding those differences is really important. And then we also weren't, within the data that we had available, able to account for any of the protective factors that might be at play here. We also weren't able to account for any of the other broad minority stress or social stress related factors, because those just weren't included in the assessment battery. And so I think having future research pulling some of these things in, understanding sort of how minority stress is at play and what are social stressors beyond just adverse life experiences and other acute stressors that are really having a significant impact on the development of pain and pain progression. Next slide. So just to end on a few clinical implications, I think routine and inclusive assessment of these identities is crucial. These items should be included in the demographic section of our questionnaires, along with other aspects of identity that people are reporting on. And I mentioned this when I was presenting the open-ended responses as like a part of this assessment, but excuse me, monitoring for iterations and evolution of language and the emergence of new identities is also really important. Relatedly, this is something that we should be asking kids repeatedly. So it's not just like they come in for their initial evaluation and you ask it and you understand that that is a fixed identity. What we're seeing more and more is these identities are being sort of experienced in a much more fluid way. And so having it as part of our standard of care and in our research, that we're asking repeatedly what people's identities are. Next slide. I also think when we think about pain care, it's just important a one-size model does not fit all, even within a population of youth who identify as sexual and or gender minority. And I think this move towards precision medicine over the last decade really recognizes that individual differences in the pain experience and addressing those individual differences is imperative if we're thinking about equitable pain care. And given the role that psychological distress is potentially playing here, our treatment approaches for these youth should not only target pain and functional impairment, but also address the psychological impact of minority stress that they might be experiencing sort of outside of the context of their pain. And I think adequately addressing these factors could help us alleviate stress and improve coping. But it's not going to eliminate the disparities in the pain-related outcomes. And so I think we see sort of the disparities in mobility, fatigue, and sleep even after we account for psychological distress. And that suggests there's these broader systemic and structural factors that contribute to pain inequities and shape health outcomes. And I think sort of where we're sitting here in the States is that clinicians, there's sort of this intersection that's happening between like research and clinical work and public policy. And so recognizing that we have these socio-ecological determinants of health that are leading to worse outcomes is really important. Next slide. I think, yeah, just have thank you for the patients and the families who participated in this work and for my research team on these projects specifically. And then the next slide is my wonderful research lab that I have feel very fortunate to work within, and thank you.
Thank you so much, Lauren. That was a brilliant presentation and something, you know, that we've discussed before, how important this piece of work is. And certainly in our specialist pain services here, sexual and gender minority youth are definitely overrepresented. We've had quite a lot of questions in the chat and we haven't got loads of time, but I'm going to try and sneak one in myself before we look at those, if that's okay.
Of course.
So you kind of talked about best practice around assessing sexual orientation and gender identity. And I'm just wondering what advice you might give services that want to measure whether they are genuinely inclusive of SGM youth and how we might do that.
So like from like a patient's perspective, like did the patient feel like the I mean, I think like the thing that's like coming to my mind is just to ask. And that looks different, I think, clinically and from a research perspective. But clinically, like we have made a push to have like our name and our pronouns on our badge. I think we're moving towards a space and, you know, people are trying to walk into patient rooms and say, you know, I'm Lauren Harrison, I use she, her pronouns. How do you like to be referred? And people will answer that however they choose to answer that. I think we've had a lot of conversations amongst our team about navigating that as providers and how it can feel a little uncomfortable as providers, and really trying to think about what is that saying and where is that discomfort coming from, and how do we like name and normalize that, but still be able to walk into a room and identify ourselves so that we create space for the people who that question will really be impactful for to share their identities. One thing I saw recently, not in our pain clinic, but at like a care clinic that I went to, I had like the flu that everybody had at the new year, was that as patients were checking in, they had stickers that had pronouns. And so the patients could just pick it up and put it on their shirt. And I just thought that was like a really nice way to signal to providers what their pronouns are without them having to interject and say, or without the provider even having to ask. And so I think there's probably a lot of ways, but I do think that at the end of the day, circling back and saying like, do you feel like we captured your identity, or did this feel inclusive or representative, and why or why not, and being open to iterate and flex.
That's great, thank you. So we've had a question on here from Rebecca Taylor, and she said that you mentioned using feedback to reconstruct the items on your scale. So I think that was the assessment scale. Did you use methods like cognitive interviews for this feedback, or was it based on statistical responses to the items?
Yeah, that's a great question. So the items that we ended up putting forward in the feedback process I presented on was done through the Trevor Project. So we didn't collect those data. But what the Trevor Project does every year is send out large nationwide surveys to um, queer youth, and then it assesses mental health, it assesses all aspects of sort of functioning, and then they were using their feedback to really iterate and refine these items. I don't remember off the top of my head the analyses they did, but I have like the full written report that describes the development process, that I think is actually really interesting and presents sort of a more expanded way, or expanded data on what I very quickly presented. I'd be happy to send that to you, Jen, if you wanted to circulate
Yeah, that
that
would be
and just
great.
read, because I think what they were also doing was developing those items based on responses from people with the lived experience, which I think is really important.
That actually fits with a couple of other questions that we've got. I think a lot of people are interested in the process, and the next question from Mairead is she was curious as to whether there was a process followed to involve people with lived experience in the research and how your research team achieved this.
Yeah, so in these data that I just presented, no, but I have, excuse me, I had another, like a small qualitative interview study that I can just see David's question, and I love David, and he always asks me these questions. That was really focused on, from a qualitative interview approach, understanding the intersection of being gender diverse and having chronic pain and also being neurodivergent. And I had a patient partner, Emmett Kalish, who was a patient in our pain clinic, and then the physician that they were working with connected them with me, and they're now a patient partner in my work. And they really helped me like come up with the interview questions and get feedback from youth after and shape those. And then I have a grant that I have now submitted twice, that I'm hoping will get funded, and had Emmett and another queer patient partner involved in that as well. So, and how I reached those people, Emmett came directly from a clinician, and then within our lab we have a panel of people with lived experiences, and I presented the study to them, or my idea of what I wanted the grant and the project to be. And this individual connected with me. So they've both worked with me on like the writing and the rewriting and refining of the grant. And then we'll be involved in the project as well.
That's brilliant. Thank you. So I'll read out David's double questions for those who aren't reading the chat. So David said, "Hi, Lauren, amazing talk, so striking, somewhat unsurprising question from me, but do you also measure and record neurodiversity, neurodivergent conditions in your patients?" That's the first
In the
part.
clinic registry, no. And that is sort of like undergoing a big overhaul. I think also if you're familiar with the PROMIS measures, the versions that are included in our registry are the computer adaptive testing ones. And there was a paper, I think, that came out a couple of years ago looking at, when we're looking at outcomes longitudinally in youth with chronic pain, what are the best versions of the PROMIS measures to include? And not surprisingly, it's not the computer adaptive testing ones, because people are not necessarily getting the same items each time. So we're overhauling that to include the short versions of all the PROMIS items. And in doing that, are significantly overhauling the demographics section that will include sort of specific assessments of neurodiversity. And before we added these items assessing sexual orientation and gender identity, youth actually didn't complete any demographics. It was all parent reported, which I think is also, yeah,
Gonna miss a lot.
something that will be changing.
Good. And the second part to David's question, so it's probably the last question now, is I wonder how many of the youth in your study are out both with families and with other aspects of their lives?
Yeah, that's a good question. I don't know off the top of my head, but we do have in our assessment battery, we have these demographic questions that the kids fill out. And one of the items says, have you shared this identity with your parent, yes or no? So clinically, providers know that walking into the room, and can ask that either in a confidential way or outside of the context of the initial eval. But we do have those data in the data that I looked at, so I could look, but I have not looked. But
I guess it'd be interesting, more information, isn't it?
yeah,
So I'm just conscious of time, but I want to just say the biggest thank you, Lauren, for coming to speak to us, and to everyone who's joined us this evening, or morning for Lauren. Keep an eye out for our next Pain Forum, which will be coming at the end of spring. And as I said at the beginning of the talk, we will be sending out an email after this, which will have a link to the recording in case you missed any of it. But you can also get it on our website, and all of our previous pain forums are available to access on there as well. We'll also put in our contact details for our education team, where you can ask to go on our email list, which will send you lots of other education events and courses that we run from Bath. And I think we will finish there. Thank you, everyone, and good evening.
thank you so much.